So UNICEF aim is to establish effective strategy for cholera control and prevention, firstly in the Horn of Africa and in the Zambezi Basin. Our common goal is to better understand the dynamics of cholera at national but also sub-regional level, taking into account cross-border spread of outbreaks. We apply an approach combining field research, epidemiological analysis and biomolecular analysis. And one of the targets is to identify cholera hotspots, high-risk population and practices, so that we can have a targeted and efficient intervention during emergency, but as well for the long term. Next slide. So this is over to Stan now.
Okay. I had a connection problem, but I'm back. So the study region will be divided in two separate regions. The Greater Horn of Africa in the north, including Somalia, Kenya, and South Sudan. Ethiopia was initially included in the study, but was discarded for, let's say, political reason. The other countries of the Greater Horn of Africa usually includes Djibouti and Eritrea, but they will not be part of the study in as proper countries, although Djibouti was shown to be the actual entrance of several cholera epidemics in the area in the past. Further south, we will study several countries of the Zambezi Basin, including Angola, although this country, at least its western part, is epidemiologically more connected to the Democratic Republic of Congo, Zambia, Zimbabwe, Malawi, and Mozambique. It's important to understand that although those 8 countries are part of, let's say, kind of administrative areas, all of them are connected and are deeply connected to the big Great Lakes region that lies in the between. Next slide. Thank you. So, what are the study outputs and deadlines? So, you may have read already our inception report that summarizes the proposed methodology, the work plan and deadlines, and the time of payments. We are currently working on a literature review report, which includes informations on cholera burden, outline of cholera dynamics, and the main risk factors in the region, which summarizes available information on cholera control and prevention interventions, including oral cholera vaccination. And this report will also summarize its findings concerning economic costs and benefit on interventions whenever those informations are available, of course. The next step will be field missions. And the first outputs of those field missions will be a field research report for the Horn of Africa and another for the Zambezi Basin. Those field research reports will include surveillance data on cholera, will list the cholera samples or isolates that could be collected and shipped to a laboratory for further genetical analysis, and will summarize investigations conducted in pre-identified hotspots areas in the visited countries. And after those field research reports, we will deliver an in-depth epidemiological report, one for the Horn of Africa and another one for the Zambezi Basin. And those in-depth epidemiological reports will describe cholera dynamics, risk factors, and high-risk populations. Will propose the hotspots which have been identified using the methodology we will show you later on. We'll propose strategic recommendations regarding cholera prevention, preparedness, and response, and recommendations on how outputs of the study can be mainstreamed in relevant national policy documents. And at the end, we will deliver cholera control and prevention fact sheets on the model we will show you later on. And those fact sheets will be delivered by mid-December this year. Next slide, please.
So, thank you, Stan. I will continue this platform speaking about the method and the data management and the analysis. So, we will apply the same methodology that we used previously in West Africa. It's based on the study of the long time series analysis of the cholera cases by country. Basically, on the case series, case and death over a very long time period, if possible. We are using 8 to 9 years. We will define at the lowest administrative level possible, often is district level or department region level for the big countries. Or, for example, for Nigeria, that we will look at later, it was the local government area. So from this time series at a lower administrative level from a long-term data set, we will link that with the GIS in the GIS environment in order to describe and map the cholera burden and the hotspot. We are using as well ancillary data in order to put into the context the epidemiological information, such as WHO indicator or WASH indicator. From the review of literature from the colleagues that they were describing already, we will put into the context as well the grey literature and published literature, either from sources such as PubMed, Embase, or ReliefWeb, or the UN agency report and NGOs. How we proceed later on for the analysis. First, we have a step of data cleaning and quality assessment, including the missing data, and look to outlier or error in the database. Once it's done, we had often a smoothing step and an interpolation where the data were not available. It's not often the case, but it can occur. Then from there, we are focusing on extraction of the outbreak. I mean by that, on a long-term time series, we will extract the successive outbreaks that occur in a given place and describe them according to their epidemiological feature, such as the length, the number of cases, the duration, the incidence, the case fatality rate, etc., etc. From this set of information, we will define at that lower level of admin unit the hotspot and the behavior of the cholera in this specific location. And from there, we will map it. Next slide. Okay, this is an animated slide. So we'll start from the top. This is the algorithm. It describes the simple algorithm we are applying on the data, on the top of the data. I should say that this algorithm was used in all the countries in West Africa. It was working well. So it's something that we were really using already and including in the process of defining the hotspot. The first step is looking to the recurrence of the outbreak. So is the area affected? Yes, recurrence. If the recurrence is low, mean that there is not often cholera outbreaks. This is not our main focus. If it's high, over the 80 percentile, then we will look to the duration. There is a frequent outbreak, and then are they from a long length or a short length? And if they are places where we have not only recurrent outbreak, but they are long, and then they represent a significant duration, they will be of high priority. With regard to those who are still of high recurrence and duration, if the incidence is low, they are ranking at medium priority. There is an echo. That's okay for the sound because there was an echo.
It's good now, Bertrand.
It's good now. Okay. So if the recurrence is medium, so we are in the branch on the top called medium between the 16 and percentile. Then we are looking, as we did previously for the I, for the duration, splitting into the places where you have a low duration, and then the places where you have a high, medium duration to high, medium to high duration, which is the type 2.
Hold on, Bertrand. Hold on, Bertrand. Excuse me, Shonda Piwa, can you switch off your mic, please? Okay, great. You can go on, Bertrand.
Okay, just go back to the last slide, the previous slide for the last. Okay, and then we have the type 4, low priority, which is the one where the incidence is still low, but sometimes we may have high CFR. This is typically the case on the border of main cholera hotspot when the outbreak is coming outside of the main places where the local health system is used to manage a cholera outbreak. You can have expansion of this outbreak to places where this is short outbreak, but there is a high CFR. So these 4 categories are typologies of cholera outbreak by special unit and by time, and we will use it to map it. Next slide. So that's the example of the cholera fact sheet that we made on previous project for West Africa, which is split in several blocks of information, general time trends and description of the cholera burden. Then we are looking more into the details with an incidence cholera map and a description of the main location affected. At here it's Nigeria, so it's at state level. The first page, and you see the table on the bottom giving the burden of cholera over 10 years by state. So we can already focus on the brown zone that we see in the map in the right. And then we had a time graph with the occurrence of the outbreaks according to the seasonality that we see the blue bar where you have the rainfall. Next. Then this is the zoom of the cholera cases over time by week and months over 10 years, few years period. Here it's 7 years period, I guess. Then it show you the seasonality where at which period we should be prepared to see a new cholera outbreak. Next slide. Next. And the zoom on the map. Next. Then, from this general overview, we extract from the great literature, we will extract information that are contextual information about livelihood groups, practice at risk that identify in the society a subgroup of population susceptible to or at risk to be exposed to the cholera. Next. This is one of to illustrate if the data are good and are available, how far we can go in terms of spatial resolution. This is Nigeria with the hotspot classification. So we have our 4 types of hotspots, and then symbolized by the square of different color, and we go at LGA, so local government area, applying the methodology I just showing you. So here the end user of the map can really choose and look at where they would like to do the cholera prevention and control measure. Over to Sandy, I guess.
Okay. So here's an example of some of the genetic analysis of Vibrio cholera strains that we've performed in West Africa. On the right, we have the MLVA genotype results, which shows the connection between different outbreaks and also the genetic evolution of strains within an outbreak, color-coded. And at the bottom is some of the same strains plotted onto the 7th pandemic tree to show their relationship with other epidemics. So this type of genetic analysis enables us to characterize the Vibrio cholera strains that are responsible for outbreaks. It also gives us major insight into the dynamics by showing evolution, for example, a relationship with other outbreaks and also confirms epidemiological findings and field investigations. So, however, to ensure sample collection, there's a few conditions. It's really essential to have a partnership with a national reference laboratory that's able to store the strains and collect them and subculture them and also willing to share them. And another option, or if this is not the case, we could also do on-site collection using filter paper direct from patient samples, for example. And second, regarding sample shipment, which is sometimes complicated, there's a few different options. So Vibrio cholera isolates can be shipped. I've listed 3 different forms. Ideally, either they would be live subcultured in enrichment broth and shipped directly to France so that we can continue to grow them and then isolate DNA for further analysis. If this isn't possible, then they can be subcultured in the country, and then the sample would put into lysis buffer. This would kill the cells, and then these non-infectious samples could be shipped. And as I mentioned earlier, we could also just simply ship the stool samples on dried filter paper, which is also non-infectious. Next slide, please. So here is, So here's our project timeline. Given the, well, obviously we're going to have to shift the dates a little bit, but up at the top you see that the inception report is, we had set for the end of July. And like as Stan mentioned, we're working on the literature review right now, which would be finished in the beginning of September. After that is going to be the field mission for the Horn of Africa. So first it would be Kenya and Somalia. From Somalia would be done remotely, and then Ethiopia. Before we leave, ideally, if we had the epidemiological data, we would do some of the analysis before we leave to find hotspots, so that when we're in the fields, we can directly visit some of the hotspots. And then afterwards, we would do we would continue the epidemiological analysis for the Horn of Africa. And then ideally later on in October or beginning of November, we would do the field research analysis, the field mission in Zimbabwe and Mozambique, and Zambia, Angola, and Malawi. Same thing for the Horn of Africa. We would ideally, if we have the data before we leave, we would be able to identify hotspots, visit these hotspots in the field, and then continue the analysis after the mission in November. And then, as Jessica mentioned, I think after this is all done, we would do the cholera control and prevention fact sheets for mid-December or end of December. Next slide, please. So to ensure that all goes smoothly, we have a few requirements that would really help us with this mission. First of all, as I mentioned, we would really need to have cases in depth information per week, per district, from at least 2006 to 2017. We had mentioned that it would be ideal to have this kind of information 2 to 3 weeks before we actually go into the field. Also, to really find hotspots within like certain sites where there's often outbreaks, we would ideally like to have line lists of cholera patients from 2006 to 2017. Also, other requirements would be the matrix 4W from Health, WASH, and CD4 clusters, the cholera control and prevention strategy guidelines, the action plan for WASH, Health, and CD4, and the PCA donor reports for WASH, Health, and CD4. Next slide. Also, to ensure that everything goes smoothly before we arrive in the country, a lot of appointments would have to be set up with key cholera stakeholders, such as the Ministry of Health, disease surveillance, the focal person for cholera control and prevention, the reference laboratory, the national reference laboratories for the collection of Vibrio cholera samples, the WHO, the Ministry of Water, the focal person for cholera and control and prevention with the Ministry of Water. Also, the focal points in WASH Health and CD4 cluster. Also, the WASH Health and CD4 stakeholders involved in cholera control and prevention, and any other relevant organizations such as public health in the country that could help with this mission. Next slide, please. Okay, continue of requirements from the country offices. The authorization requests. So we would need to obtain an official mission letter from the Ministries of Health, soliciting this work and authorizing our team to access this data. It would also be great if they could introduce the research work and us, the team, to the major stakeholders in each country to facilitate data sharing and set up meetings before we arrive. And also to facilitate Vibrio cholera sample collection and shipment. We would need official authorization from made to the Ministries of Health and to the reference laboratories in each country. And next slide, please. Great. Right, so here again is, okay. Here again is some of the proposed dates for the field missions, which is most likely going to shift a bit. For Horn of Africa, as I mentioned, we would start with Kenya and Somalia, and that would be me, Sandy Moore. And then South Sudan in end of September, ideally, would be Jessica. And then for the Zambezi Basin, Zimbabwe and Mozambique, that would be Christophe. Here we have October 22nd to November 5th. Then again, Angola and Malawi, that would be me. Also end of October to beginning of November. And then Jessica would travel to Zambia, end of October to November as well. Okay, next slide.
Christophe, are you online? Christophe? Okay, so I will go on. So now we'll show you what are the opportunities for such kind of studies. So the first opportunity is to identify cholera hotspots, so that it will make things easy to prioritize intervention and to tailor intervention according to the type of hotspots. Also to engage in a targeting approach, which is the same approach that will be used in the 8 countries, similar approach. The idea also as well is then to mainstream epidemiological findings into national policy from the health and the WASH sectors to ensure that actually what is recommended could be implemented, and to document cholera control and prevention strategies. It will also hopefully increase the visibility of cholera as a public health issue in your country and provide comprehensive information for advocacy purposes. The fact sheets are very useful for donors. They can have comprehensive information in 2 pages. It will also provide decision makers with evidence-based information to implement efficient prevention and control activities. As you've seen earlier, you will have really tailored information on communities at risk, practices, things like that. It will also hopefully help to mobilize resources for cholera prevention program in cholera hotspots as long-term investment and not only as emergency or preparedness intervention. Next slide, George. Thanks. So this is the end of the presentation. You can contact us. So there is contact details for Jessica, Sandy, and Christophe. This is the three of us who will go to field missions. So as a reminder, I'm going to South Sudan and Zambia. Sandy is going to Kenya, Somalia, Angola, and Malawi. And Christophe will be visiting Zimbabwe and Mozambique. So don't hesitate to contact us, or we will do so to move forward on this study and hopefully have a good implementation of the work. Thanks, George. That's it.
Okay, thank you very much, Jessica and team, for this excellent presentation. Before we go to questions and comments from the country offices, maybe a couple points from my side. This study obviously is not a standalone activity. I mean, it really falls within the regional cholera framework that was recently devised for East and Southern Africa. And that framework really aims at a better targeting of our cholera interventions, whether we're talking about preparedness or prevention. And this is to be done through the identification of cholera hotspots, which is really the purpose of this study. Now, a study is only as good as the data that feeds into it. It's true for this study, it's true for all studies. And here at the regional office, we're trying to get some of the data that the research institute needs, mainly via WHO at the regional level and also the Global Task Force for Cholera Control that sits in Geneva. But really the involvement of the country offices is crucial, just because a lot of the data is really only present at the country level, either through our offices or through the local ministries of health or through the local WHO offices. So we did send those requests for data to all the country offices really, and I know a lot of you are working on it. But really, this is just to reemphasize the point that we need the active involvement of the country offices. And after this WebEx, the Research Institute will start engaging you bilaterally to obtain this data. A second point is regarding focal points. Obviously, we would need a focal point from each country office to engage with the Research Institute. As part of the drafting and dissemination of the Cholera Bulletin, each of our country offices have assigned focal points for information management purposes. So we don't want to be prescriptive. I mean, it's really up to each country office to decide who should be the focal point for this study. Ideally, it should be somebody from the health section. Again, it's really up to the country offices to decide, but a health professional is probably in a better place to obtain data and authorizations from the ministries of health than a WASH or a C4D person. But we leave it up to each country office to decide, and after this WebEx, we will send an email to all 8 country offices reiterating the type of data that we need, but also asking them to assign a specific focal point for this study. Now, with this in mind, we can actually start taking questions. I see a question from Edson Montero from Angola. The question is, the documents are already translated in Portuguese, or do we have to do it to present it to the government? Okay, and the second question is, WHO involved? We will need to inform them as they are the leading agency. I can start by answering the second question. Yes, WHO is involved, so both at the Geneva level and at the regional level. The country office level, it's really up to the participating UNICEF country offices to get in touch with the local WHO office. And in terms of translation to Portuguese, I'm afraid that's not part of the terms of reference of this contract, but this is something that we can discuss bilaterally later on, Edson, to try to find a solution. Edson, does that answer your questions? Yes, thank you. Okay, a question from Bajwa, the Chief of WASH from Somalia. Somalia to be covered remotely. What does that mean? What will be the implication? Jessica, do you want to answer that particular question?
Yeah. So for Somalia, Sandy actually is going to stay in Nairobi for 2 weeks and contact the agencies and other partners which are based in Somalia and actually acting remotely. It was a bit difficult for us and challenging for security concern to organize a field mission in Somalia. So the implication obviously will be that we won't be able to meet the authorities in country, and it might be more difficult to get information, but also to really present the objective of the study and work with the authority together with them on the output and the outcome and the use that can be done later on. So yeah, so that's it.
Okay, thank you. A question from Jesus, WASH specialist from Mozambique. It will be helpful from country offices if ESARO contacts AFRO to send messages to all their country offices as an entry point for our engagement. Is that possible? Yes, we are already in contact with AFRO through our regional health colleagues, but we can check with them if it's possible to have that communication. Nevertheless, it will still be useful if the UNICEF country offices also try to engage the local WHO offices just to make sure that we have all our bases covered. But definitely we'll talk to our health colleagues and we'll see if there's a way for the AFRO office to contact directly the WHO offices in the countries. A question from Meki from Zimbabwe. We would require these documents and letter to introduce the research to all relevant stakeholders and soliciting for their support beforehand. Meki, can you give us a bit more detail on what you mean by that? You can speak, you don't have to type. Okay, no answer from Meki. We'll go back to him. Charles, cholera in the Horn of Africa is cross-border. In the absence of Ethiopia, will this be a major problem to the findings? Okay, this I can answer, and maybe Jessica can complete. Originally, the plan was to have Ethiopia, Kenya, and Somalia as part of this study. Unfortunately, for various reasons and the sensitivities around cholera or AWD in Ethiopia, our office there did not feel comfortable with going ahead with this study at this time. So that's why we replaced it with South Sudan. But I fully agree that this could be an issue in terms of better understanding the cross-border implications of cholera transmission. Jessica, would you like to talk about this?
Yeah, obviously Ethiopia is a major pieces of the Horn of Africa, so it will be difficult to have an in-depth understanding of the cholera dynamics in the region without Ethiopia. Yet when we are doing the literature review, we included Ethiopia, so we already have some historical information and on cholera dynamics in the region, which imply actually very high transmission between Ethiopia, Somalia, Kenya, and South Sudan. So we will at least have this information in the report. And actually, it's funny, but it's funny. Ethiopia has a long history with cholera. There is reports which go back to like 19th century. So it's a long history with Ethiopia and cholera.
Okay, thank you, Jessica. From Jacob, it will be good to share the documents with us. Yes, a lot of documentation has already been shared with the chiefs of WASH and the chiefs of health, but you can get in touch with them and they'll probably give you the documentation that was already given to them. And obviously, as the study evolves, more documentation will be transmitted to the country offices. From Charles, again, from Somalia country office, the study seems to be from a WASH perspective. How much is health section involved in the research? Well, Charles, the regional cholera framework for the region, but also the study is done in cooperation between WASH, Health, and C4D. And really, even if the results themselves will be used by the WASH section, and specifically for WASH programming purposes, the health section is extremely involved because it is, after all, a health epidemiologically study. Jesus, thank you, George. Can you send us a copy of the communication to support our discussions in country? Yes, absolutely, will do. And a precision from Meki in Zimbabwe. I mean the regional office to share the presentations and communication to country offices for onward sharing with stakeholders. Yes, a lot of the documentation has already been transmitted to the chief of WASH and the chiefs of health. This presentation hasn't, but we will definitely maybe resend an email to the chiefs of WASH and the chiefs of health and the chiefs of C4D with all the documentation for further forwarding to the various staff that will be involved in this study. A question from Gabriel Kunin. How will C4D be involved, and especially from the field offices in South Sudan? Well, in terms of the regional framework itself, there's a whole pillar on C4D. So obviously C4D is involved. Now, in terms of the study itself, like I mentioned before, it's really up to each country office to assign focal points. Like I said, ideally from the health sections, but they could be also from WASH or C4D. So it's really up to each country office to decide on the level of involvement of their various sections in this particular study. A question from Ferdinand, WASH officer in Mogadishu. Somali is very significant for cholera control in the Horn of Africa. 60,000 cases of cholera this year. It may be useful to consider meeting with stakeholders in Mogadishu. Jessica, can I leave it up to you to give your opinion on this?
I guess we'll need to discuss this with the team and see what we can do. So we need more time. I need to discuss with Sandy and other team members.
Sure. And in any case, after this WebEx, Jessica and her team will engage bilaterally with each one of the 8 countries to discuss data, obviously, but also to further refine the proposed dates of their visits. And maybe when you discuss this with the Somalia country office, then you can see what is the usefulness or possibility of having a meeting with stakeholders in Mogadishu. Question again from Jesus in Zimbabwe. Would research protocols be shared with country offices? So we share with Ministry of Health and partners. These will need to go through their Ministry of Health ethical committee for approval. Very good point from Jesus. Jessica, can I throw the ball to you?
So actually, in the Inception report, there is already the methodology for the research, and then I guess we'll have to develop research protocol for the sampling parts if we do clinical, if we do on-site collection of samples. So we'll discuss this with each country offices. It will depend if there is a cholera outbreak which is ongoing and if it's in the capital as well, because we only have 1 week mission for each country, which will render difficult for us to go on on districts which are far from the capital. So it will be done country offices by country offices. But you don't need ethical committee approval just for the data analysis, the fact sheet process, and which are not even involving strain analysis.
Right, thank you, Jessica. Another question from Jesus, which I mistakenly said that he is from Zimbabwe. He's actually from Mozambique now. And,
Sorry, just a question from our health colleagues. Yeah, this is Frederico Brito from Mozambique. So on ethical review, I just want to say that in Mozambique, it's not only research that's related to data collection of blood sample that need to be approved by ethical committee. Other studies, even like this, related to epidemiological data series, when these studies are meant to be utilized in terms of policy change, it requires, of course, some review of the ethical committee in the Ministry of Health. Even the administrative authorization will not be given before that review. Of course, we will take the inspection report and see if this document has all elements that can be shared with the Ministry of Health and hopefully the ethical committees and be accepted as a document that can be implemented in country. So we have this limitation. Particularly, I don't know for other countries, but particularly in Mozambique, anything which related to manipulation of data, it requires some approval as well.
Thanks, Jesus. So, as you said, yeah, great if you can go through our inception report and tell us if it's enough for you to get approval. In West Africa, we had the case with Nigeria and Ghana, out of 12 countries, where it was a bit more complicated and we had to go through a more formal process even for data collection and data analysis. So.
Okay, thank you, Jessica. Another comment still from Mozambique. Are there national research institutions that would need to be involved on the analysis as well? We assume this is okay and considered in the methodology. Jessica, what do you think about that?
Yeah, it's very much welcome, and we actually worked in Ghana with also particular research institutes. So I would say that any research institute in country which are interesting in being involved in the study, either for the epidemiological analysis or for the laboratory work, are welcome. Okay.
And finally, there's a comment from Charles regarding C4D. The study findings will definitely help to inform targeted social mobilization interventions. And yes, absolutely. I mean, the whole purpose of this is to identify the hotspots so as to better target all our interventions, whether they're WASH, health, and indeed C4D. Okay, I don't see any more questions or comments. Is there... Oh, here we go. A question from Chanda Piwa. It would be useful or helpful to consider meeting WASH cluster members to get their views. Yes, Jessica?
Yes, it's actually planned in the list of people to meet, so in the requirements. It's really key for us to meet WASH cluster members to actually see what is the current intervention in the field, emergency preparedness and long-term intervention. So we will do a summarize actually what is done in the country for WASH, health, and C4D. So yes, it's helpful and key.
Okay, very good. Thank you very much, Jessica. Colleagues, any more questions or comments? My colleague Bernard from the regional office is reminding everybody that this presentation and recording will be posted online and link sent to you in the next 2 days. And I think this is a good segue from Bernard into the last or into the next steps. So what we'll do following this is that obviously we'll send you the presentation and the recording as Ben mentioned, but we will resend the documentation of the study. So namely the terms of reference, but also the inception report. And with that communication, we'll also ask each country office to identify 1 or 2 focal points that will be the main contact for the research institutes for this study. Okay, well, thank you, everybody. It is now 11:02, and we've reached the end of this WebEx. Thank you very much to all for having participated. And obviously, this is not the end. This is just the beginning of the study. And we look forward to interacting with you in the coming weeks and months. Thank you to Prospective et Coopération for this very good presentation. And again, thank you for all the participants for having taken the time to attend this. Have a very